With us this afternoon. It is my pleasure to present today. So, we all know that the CAD/CAM technology were restricted to restoration like only inlay or veneer or a crown. But with the evolution of the 3D software and fabricate a surgical guide, so the CAD/CAM technology has evolved. It's not only evolution in the CAD/CAM technology, also in a prosthodontist. To be a prosthodontist, we have a lot of choice and material that can be used. Zircon, EMAX, a lot of cementing material. Also as a surgeon, there is an evolution. We have a lot of different material that can be graft and prepare the osteotomy site before we place the implant. Also, there is an evolution in implant dentistry, design of the implant to create our emergence profile, the connection of the implant, the surface treatment of the implants. Add to that the software itself. We have an evolution in the software, so we can see or practice the implant placement before we go to the surgery. And we can see the position of the implant in this software. All of this evolution are useless without this word, planning. So we have to plan well to get a good result. So what I will hit in my presentation today, I will talk about the importance of the treatment plan. What is the importance of the treatment plan? Then I will talk about the analog approach versus the digital one in implant dentistry, and tie everything together in a couple of patient presentation. Despite of all this evolution in implant dentistry, and software, and pros, and perio, and surgery, one thing for me is still consistently not changed, which is the implant is still prosthetically driven. What I mean by that, before the implant was placed is surgically driven. Where is the bone? The surgeon opened the flap. Where is the bone? He placed the implant. But now the game are changed. It is prosthetically driven, which means where this is the crown, the implant should be. Okay? So performing is something dominated nowadays. What I mean by performing is doing things, taking impression, placing implant, doing root canal or composite filling. But this is not challenge nowadays. By the time, by experience, you can do everything. We have 1,000 of lectures, articles, conference that teach us how to do things. But the challenge now is to put a treatment plan for the patient. So you have to step back one step and think about the treatment plan. So let's talk about the importance of the treatment planning. Here, like the surgeon placed an implant in tooth number 10, but the angulation was not favorable for the prosthodontic to restore it. Okay? So I end up using a titanium abutment, custom one, put an opaque dentine to mask the discoloration and place the crown. But the result was fine, not bad, but it is not like what I want. This is an illustration of where the implant was placed, and this is the angulation. Okay? It's supposed to be, if it is prosthetically driven, in this direction. So it needs from me an adjunctive steps, which is bone graft or guided bone regeneration. The surgeon took the easy way, which placed the implant bone driven, not prosthetically driven. So if we look at this case, just look at this case and ask you, what is your diagnosis? What is your diagnosis? This is a mandible, maxilla, right and left, and the frontal with the OPG. It's enough to give a diagnosis. What is your diagnosis here? The diagnosis, I'm talking about diagnosis, not the treatment. Yes, what is your diagnosis? What else? General periodontitis.
This needs CBCT because OBG.
No. I'm talking about diagnosis only. I am asking about diagnosis, not the treatment plan. Yes. So if I ask you, what is your diagnosis, which is the basic, it is partially edentulous patient. Partially edentulous patient. A class 1 in the mandible, Kennedy classification, modification 1, and class 3 in the maxilla. This is the basic. If you want to get the treatment, it could be removable, it could be fixed, it could be implant. Here I have to go for further investigation. But the diagnosis, to know the diagnosis, you will know the treatment. Okay? So this is the diagnosis. If you look at the ridge, placing implant here is not challenging at all. We can open a flap, we place the implant, we have enough bone, but restoratively, we have a challenge because we don't have enough space for the crown. So it is not about placing implants. Osseointegration, it is given nowadays. We don't have any challenge in osseointegration in implant. Our challenge in the prosthetic part or the treatment planning. The treatment planning. So what I have to do for the full mouth rehabilitation, I have to mount the cast, the maxillary and mandibular, in a semi-adjustable articulator on a centric relation. Okay? Then start with the starting point. I will not go in details in this. My incisal edge position is where. Then I built the smile, canine to canine, then the mandible, then I go to the posterior area, which I use some reference to set up my wax up. Then I get the full wax up for the case, okay? Then I duplicate this wax up into radiographic stent using a cataberca. Send it, give it to the patient, send it to take a CBCT, see where is the location of this cataberca. It gives me an indication the amount of bone underneath. This is the conventional way of the treatment of the implants, not the digital one. We used to do it like that, okay? And this evaluate the CBCT and start the implant planning. Place the implant using the manual or freehand surgical stent. Okay, then this is the patient after we finish the treatment. This is before and this is after. Okay, this is the full mouth. This is another case, partially edentulous patient. How do you treatment plan for the implant? In the conventional way, we have to take a conventional impression. Then diagnostic wax up, then duplicate this wax up into a radiographic stent using cataberca. Give it to the patient, ask him to go to take CBCT. Okay? Then later we use this stent as a surgical one. This is the conventional way, the step by step for the conventional way. So this is how it looks in the CBCT. Where is the marker? Where is the position of the implant? This is the conventional way. This is the full wax up. So what I want to place the implant in the middle of the tooth for a biomechanical biomechanics of the implant. Okay? So implant treatment must be prosthetically driven. What I mean by that, we have, if you want to refer the patient to place an implant, like you have to write a prescription for the oral surgeon about that. What is the prescription? Articulating the diagnostic cast, upper and lower. Do the wax up, fabricate a radiographic guide, obtain a CBCT with this radiographic guide, fabricate a surgical guide, then place the implant. So this is the steps of the conventional way or the analog way of placing the implant. Mount the case, wax up, radiographic, CBCT, then surgical guide, then place the implant. Another thing with that we have to understand, it's about implant placement and the loading protocol. There is two protocols for the implant placement and for the loading of the implant. For the implant placement, immediate, which means that I extract the tooth, place the implant at the same time. This is called immediate. Early, within 2 weeks. Conventional, after 2 months. 2 to 6 months. This is for the protocol of the implant placement. For the loading one, also the same. Immediate at the same day, early within 2 weeks, conventional after 2 months. So immediate at the time of the extraction, early within 8 weeks, sorry, conventional after 2 months, 4 to 6 months usually. Okay, so the implant placement protocol. Immediate one at the time of extraction, early 4 to 8 weeks, conventional one 2 to 6 months. For the loading one, after you place the implant, the loading one also we have immediate, the early and conventional one. In 2002, it used to be in this same day. Immediate, it means that we have to immediate load the implant in the same day. Later on in 2004, it became within 48 hours, not 1 day, 2 days. 2006, within 3 days. 2007, a week. So you have a week to load the implant. We have a week to load an implant. Why this? Like the change from 1 day to a week to loading the implant? Because it changed the surface of the implant, the micro design, the macro and the micro, the implant surface, the geography. It is like this, the threads, the surface treatment. It's changed in the implant. We used before machine surface, not sandblast, not laser treatment. So by this time, all this surface treatment to increase the osseointegration and increase the primary stability and decrease the healing period. Okay, that's why it shifts from 1 day to 1 week to load the implant. It's not only the first day. You have up to 1 week to load the implant. Okay, so what do you want to know about loading of the implant? When we place the implant, you have a mechanical retention because of the threads, the design. If it is taper, cylinder, it is mechanical retention. After 2 to 3 weeks, the biological one starts, which is the osseointegration, the cell formation and that. So you have to avoid this period, which is called the stability dip, 2 to 3 weeks. Here you have to avoid the implant loading. But in the beginning, you have up to 1 week to load this implant, and the loading will be with the temporary provisional, not in the permanent one. Okay, again, implant treatment must be prosthetically driven. Why? First of all, you have a nice emergence profile. You will create a nice emergence profile, which is aesthetically pleasing. Proper implant position. Proper implant position. Easy to clean for the hygiene of the patient. Control of the occlusal anatomy. So if you have the implant in the middle here, so it is occlusal anatomy, it will be fine. Not in the ridge, not in the cusp. Okay? Occlusal load will delivered axially, so it is favorable from biomechanical side. And the abutment selection will be easy. So that's why we are looking for the implant to be prosthetically driven. Where is the crown is where is the implant should be. It's not surgically driven, it is prosthetically driven. So, another thing, success and survive. It is the same or different. What is this? Survive. It's not success, survive. This one, survive. This one, success. So it is different between success and survive. So what is the key now? We're talking about implant to be prosthetically driven. We have to avoid the complication. We need the implant to be in a perfect position. We don't want the bone to get resolved or the pre-implantitis or pre-mucositis. What is the key? Diagnosis is the key, which we miss in the dentistry. I am teaching in dental school, okay? I found that all the residents and the students are weak in diagnosis. It's the first things. If you know your diagnosis, you know your treatment. Implant is a machine surface. It is an easy part. The most difficult part about the implant is the diagnosis. Okay? So what is missing in dentistry? You have to investigate, analyze, assist to get the diagnosis. Like in the beginning, I ask you one question. What is the diagnosis of your case? all of us went to the undergrad and we know Kennedy classification, but no one answered me. Okay, so think about it. Diagnosis is the most important part about dentistry. Implant 1, investigation, analyze, and assessment to get the right diagnosis. Okay, we talk about the conventional or the analog one. Okay, now we were gonna talk about the digital part. So the step of the analog, impression, mount the case, diagnostic wax up, duplicate, CBCT, the radiographic stent, use it as a surgical stent. So it is a free hand. It is a free hand, not surgically driven. The digital one. What is the digital workflow? It is any workflow that occurs primarily through the use of what? Of the use of converting the analog, which is the conventional one, into a digital format using the computer. Okay? This is the digital workflow. Some concept about the digital. STL. We need the format in STL. STL is the standard utilization language. STL file. This is when we scan the patient. Okay, we will provide the technician or the dentist with what we call it STL file. STL. STL stands for standard utilization language. After the STL, what we want, DICOM, which is the CBCT. We call it DICOM. Okay? So to get the STL, we need a scanner. The scanner in the clinic, or we can use the scanner in the lab. How to use the one in the lab? We have to take the impression with high resolution material like PVS or polyether. The technician will pour it and put it in the scanner and scan. So we have two options to get the STL file. Either use the scanner in the clinic or take the impression and send it to the lab. He will scan it. The DICOM, which is the CBCT, sorry. The DICOM, which stands for Digital Image and Communication in Medicine. This is the abbreviation of DICOM. Check out to take it by CBCT. Send the patient to take an CBCT. So the first one is the STL, which we can obtain it by scanner. The second, DICOM, CBCT. Okay. The third requirement for the digital workflow, what? Software. We need a software. We have two types of software. We have an open one and we have a closed system. Okay. The open one, like we can use any implant system. The closed one is like for the company. It's like iPhone and Samsung. iPhone, only you have to use what? The Apple product. iPad or like iWatch. So closed system. The Samsung is an open system. We can use it in Android. Huawei is an Android. Okay, so this is the difference between the open system and the closed system. About the software. Okay, this is the closed one. Okay, then after that, we start to plan the implant. We start to plan the implant. Who should be plan it? The dentist or the technician? Dentist. But we always rely on what? On the technician. The technician will not know that it is supposed to be prosthetically driven or not. He don't know the vital. He don't know the anatomy. At least give him an idea. Don't rely 100% on the technician. Design the implant. Then you need a CAD/CAM machine to print or to mill the surgical guide. Okay? So, guided surgery. It is really necessary if we ask ourselves, do we need the guided surgery? It is preventing the error in the treatment plan by establish what? A restorative plan, which is prosthetically driven. This is all about surgical guide, okay? To place the implant. The reason for the guided placement are not to increase the implant survival rate. If you want your implant to be success, just put it in a mal position, it will also integrate. It is not about the survival rate. It is about to place the implant according to restoratively driven treatment plan. Okay, which I mentioned, prosthetically driven. So advantage, like we can analyze the case, study the case before we go to the surgery. Okay, increase the rate of predictability, patient comfort, less morbidity, especially if we don't open the flap, flapless technique, accuracy, and improve the efficiency of the dental procedure. This is the advantage of the digital CAD/CAM surgical guide. Disadvantage or limitation is cost, time consuming. It costs money. You need a software, you need a scanner, you need the tools of the digital workflow. Access problems in the posterior dentition. If we use the surgical guide, it has a long bear because you have to access through the guide. So sometimes in the posterior area, we have a limitation to put this bear and get the preparation of the osteotomy. So this is some of the guidelines. So to summarize this, what is the digital workflow? We have a CAD/CAM and CAI, computer-assisted image. What is the computer-assisted image? Scanner. It could be intraoral, it could be extraoral. Intraoral in the dentist, extraoral, we have to take impression, send it to the lab. Okay? Dentist or lab technician can do it. Okay? To get the STL file. STL stands for what? Standard Utilization Language. DICOM, CBCT. To get the DICOM. CAD, Computer Assisted Design. You need an implant software. Implant software. Dentist or the lab technician can do it. We have open or a closed system. Computer aided manufacture. We need to mill or to print the surgical guide. Removing, milling, which means that I put the block, it mill, remove. Adding, which is a printing, add. Okay? Material that we use, PMMA, polymethyl metaacrylate, which is the acrylic one, metal, composite, or could be ceramic. Okay? So, again, what is the requirement for the digital workflow? Scanner to get the STL file, CBCT, implant software, and printing or milling machine. So this is the requirement for the digital workflow. In digital language, STL file. I'm repeating because ايش؟ تكرار بعلم شطار بالضبط. STL file. DICOM, implant software, planning the implant, design, fabricate the guided surgical stent. Okay? Optical impression, CBCT, software to design, and machine to print or mill that. So this is the patient. She came to me with a chief complaint that I want to replace my missing tooth. I don't know if it is clear or not, but this is the pre-operative one. Frontal view. This is the occlusal, upper and lower maxilla. She concerned about this area. Okay? So this is the patient at rest. This is the patient with high smile. This is the OPG. What is your diagnosis? Class 3. Class 3. بالضبط. What is the treatment option? It could be bridge, 3-4 unit bridge, could be RBD, could be implant, fixed or removable. So what is the diagnosis? You will know the treatment. Okay? One of the diagnoses that we have, like caries, dental caries. What is the treatment? Filling. Okay? Very simple. So if we want to be more accurate, more predictable, be digital. What are the steps for the CAD/CAM surgical guide? شو الستبس بتاعت السيرجيكال CAD/CAM? To get the STL file, then DICOM, exactly. 100%. scanner, CBCT, design, then the machine to print or mill the surgical CAD/CAM guide. So this is the scanning, STL file, scanning, intraoral scanner I use, scanning, okay? Then CBCT, die. What do you need now? Software. What's the action of the software? You have to merge the STL with what? With the DICOM. So you put reference on the STL and reference on the DICOM. This is the result. You will get the merge. So the software, the first step in the software to merge between the STL file and the DICOM one. Putting this reference between the scanner and the DICOM, you will get this result.
So you put the reference before taking the CBCT or afterwards?
After the CBCT.
You count it afterwards?
Yeah, the reference you mean. Because you have this in the software, you have this and this. So put any reference, cusp, like 5, 6 dots. So the computer will realize and will merge it together.
Even for edentulous patients?
Totally different game. We're talking about partially edentulous patient. In the completely edentulous, the game is different. Okay? You will get this one, the merging between the STL and the DICOM one. So what is next? Plan. We have to plan it. Okay? Which we select from the library crowns. We have a digital wax up. We don't need the conventional one. We need a premolar and molar. So this is my position. This is where I want the crown. Okay, and it is prosthetically driven. So now I have to see underneath this crown the amount of implants. Okay, so this is the crown. So I want it in the middle of the tooth. Okay, so for the 4-5 second premolar, we go for 3.5 by 10 millimeter. 3.5 by 10 millimeter. For the 4-6, 4.2 by 10 millimeter. So this is the amount cross section of the CBCT. Okay? So we plan the implant. STL, DICOM, merge the software. The next step, what? The planning of the implant. According to the virtual or diagnostic digital waxing. We place the implant. Then we design what we call it the surgical guide. This is the surgical guide. Then we'll add the sleeves. The sleeves which is fit to the MyBill. Okay? Check the surgical guide. You have to put it in the patient's mouth. Check it if it is supposed to be not rocking. This is the first thing. If you want to use material, we call it fit checker. It will show you where it bend or show through. So we have to remove it. It's like any adjustment material to make sure it is fully seated. Because we're talking about millimeter, very like amount of errors. Okay? Open the flap, drilling, then place the 2 implants. So this is the implant, and this is the surgical kit. In the surgical report, once you print or you finalize, design the implant, the surgical guide, it will have a surgical report. It tells you step by step how to use this guide. What's the pair that you have to start, the drilling, the sequence of that, where to stop, and then we have to place the implant. So, in my case, I got a primary stability. I got my primary stability. How to measure the primary stability? Planchet is one way. ICQ, Ostel. So, initial stability of 35, use the torque. Or the ICQ or resonance frequency analysis, it's supposed to be above 65. Okay, if you want to load the implant. Loading the implant protocol, 3. Immediate, early, and delete. Conventional one. If we get the primary stability, patient don't have any complication, we can load it. So, immediate load. I place this, we call it what? Scan body. Scan body. We can read it by the scanner. So I place the scan body, I suture, and I scan inside the patient's mouth. Send the STL file. What I scan, only this side, the right side, upper, lower, and the occlusion. Don't need to scan all the arch, only the right side, if it is single or multiple, like 2 or 3 implants. So he prints using the PMMA, temporary. I insert it in the patient's mouth, then I verify it in the OPG. In the OPG, it will be like show it is closed, but actually in the PA, we have a minimum distance which is 1.5 between the tooth and the implant. Between the 2 implants is 3 millimeter. Another patient, he concerned about this area in the mandible. In this patient, I use a closed system by Sirona. Sirona have a closed system. So only the product from Sirona, we can use it. We can't use another product, okay? So the first step is what? STL, scanning. This is the scan. Okay, DICOM, put the reference, merge it in the software, digital wax up. Okay, start planning of the implant according to this digital wax up. So this is the wax up and the planning of the implant. Print the surgical guide, then use the Sirona block in the milling machine and mill it, which is removing. The first one is adding, printing. This is milling. This is the guide without a sleeve. I use it without a sleeve. So the accuracy is less than the one with the sleeve one. Place it in the patient's mouth. Make sure it is not rocking. Passive seating. Flapless technique. Place the implant in both sides, left and right. As we plan it. As we plan it in the software, we got the same result. Okay? So this is the advantage of the digital workflow. What you will plan, you will see.
For the closed system, can you use SGS for it? SGS implant?
No. It is only for the closed system.
There is no workaround?
Well, Arab way we can find. But like now, most of the system are open. Most of the software are open. We can use but the most important thing, like the one from Nobel Biocare, it gives you not the full guided. It gives you the full guided for the Nobel implant. The full protocol for the Nobel implant, but it not give, for the other system, it only give you the initial drilling. The initial drilling, not the fully guided. So this is the advantage of the open system. Okay? So we all looking for a 100 success, but my equation is a little bit different. It is 100 minus X. X what present for me? Knowledge, skills, and willingness to do things. Okay? So my recommendation, just learn step by step how to do the digital workflow. Don't jump direct. Start with the scanner. Start with the planning, with the software. Step by step. Always learn from your mistakes. Okay? And in the future, pay attention to the digital workflow. Okay? Thank you all for your kind attention, and I hope you gain benefits.